Hi, I'm Dyann Wirth, and it's really a pleasure to be here. I'm from the Harvard T.H. Chan School of Public Health, and it is my pleasure to introduce our first keynote speaker, David Walton. He's the current coordinator for the President's Malaria Initiative, and I just remind you that the President's Malaria Initiative was started by George W. Bush shortly after the PEPFAR, the AIDS funding. And David is the fourth coordinator. He's one of ours. He graduated from Harvard Medical School with his MD and the Harvard School of Public Health with MPH. He's also the first Hyatt Global Equity Fellow. He worked for many years in Haiti as a medical student and then as a resident and fellow. And I think the important thing he learned is that problem solving is actually the key to delivering healthcare. And he brings that with him to PMI. This included, I learned yesterday evening, building hospital infrastructure, overseeing the building of hospital infrastructure. He's always maintained his ties to the Brigham. It's the anchor for his work and I think his values. He spent time in the private sector, both in digital health and in portable ultrasound, again, with an eye of delivering health to those most in need. He comes to malaria with a new vision. He hasn't worked his entire career in malaria, and he really is focused on solving the problem. He's open to new ideas, but with his North Star of helping patients in the most need. And I think this gives a focus to the President's Malaria Initiative and his work, which really allows it to align with calls for better health and more universal health coverage for everyone. And so I welcome David to tell us about the President's Malaria Initiative, which has made a huge difference in many parts of the world, and to tell us his journey. David.
Good morning. It is, oh, thank you. Crowd over here. It is emotional to be back in all the best ways. As Professor Wirth noted, this is my home. This is where I cut my teeth. This is where I learned everything that I bring to my work every day, and now the U.S. President's Malaria Initiative. And so it's wonderful to see so many old friends, see colleagues, and be back. And I want to thank Dr. Ivers and HGHI for hosting us and really, again, as noted by Professor Elliott, really bringing us all together in a multidisciplinary way to think about and solve these problems. For those of you who haven't seen me in a while, a new addition to the things. The reading glasses are a little bit humbling, but here we go. So I have a rather daunting task, in my view, of talking about accompaniment. And I think for most of us, if not all of us in this room, and for many of you online, we've learned about accompaniment from the person who we miss so dearly each and every day, who lived a life of accompaniment and whose written word provides continual sort of inspiration for all of us. And so now, Dr. Ivers said, you should talk about accompaniment. And when I think about accompaniment, I think about it, again, as a daunting task, both in action, but also sort of as Paul's student and friend. And so my goal today is to less talk about what Paul has talked about. He's written so much, and we all draw continual inspiration. But rather think about my journey, the journey of theory to praxis, understanding the written word and how they've shaped the contours of my understanding of accompaniment, and how I look to embody that in my current role leading the U.S. President's Malaria Initiative. But let me start with a story. 2002, I'm looking at Dr. Jérôme here in the audience, who was with me in 2002. I was a fifth-year medical student, and in the town of Las Caobas, where our charge at PIH was to expand HIV and TB care from the single hospital that was in place, Cange, to now other places in the Central Plateau of Haiti. And so I thought I was a Harvard medical student. And so I sort of showed up and started working, and really in deep partnership with my Haitian colleagues, to sort of bring HIV and TB care to the Central Plateau. In my first few days, actually, I met a person who was a friend, became a friend, a guy named T. Joseph. And T. Joseph was dying when I met him of HIV and tuberculosis. He was skeletal, moribund. And his mom had actually already bought a coffin for him. He was still alive, but she had bought the coffin because they had given up hope. And so, of course, we give him HIV therapy, we give him TB therapy. He does incredibly well. And which frankly wasn't a surprise. But he taught me so much, not only during his recovery, but afterwards, because I learned from him to question, well, why did he get HIV and TB? What placed him at risk and shielded so many others from risk? And what does that look like for him? And what does that look like for Haiti? And how do we think about these structures and these pressures in general? And so day in and day out in malaria, at PMI, we really don't think necessarily about the history underpinning its current challenges and how malaria and those seeking to overcome it have shaped our world today. However, in my view, in order to gain a full understanding of our role as it pertains to accompaniment in global health, but particularly at PMI, I think we really need to think about that history. Again, I give you no illusions, I'm not going to do it justice. Malaria is complicated. But I do want to hit some key highlights that are, I think, critical for our understanding. First and foremost, the link between malaria and colonialism as we think about malaria in the present day. As we all know, colonization was rampant in the 19th century, with large swaths of Africa colonized by the British, the Dutch, and the French. But they faced an incredibly daunting challenge, and almost an insurmountable challenge. That challenge, of course, was malaria. In the paper Colonialism, Malaria, and the Decolonization of Global Health, Doctors Bump and Anebo of the Harvard School of Public Health detail the ways in which malaria provided an obstacle to these colonial objectives, noting how for these major colonial powers, military and business interests were compromised by the susceptibility of settlers to malaria, which was by far their most significant cause of death. They go on to say, quote, "The study of malaria as we know it was intended to protect colonial interests, not to help indigenous people or to defeat the disease more broadly. Hence, the academic study of malaria played a crucial role in sustaining the spread of disease, providing ways for Europeans to colonize more effectively, even as their activities fostered new large-scale ecology of unending malaria for indigenous folks." In the late 19th century, the British Empire continued to expand, and Joseph Chamberlain, who was then Secretary of State for the Colonies, had a vision of imperialism that could not be realized in the midst of the high morbidity and mortality caused by tropical diseases and malaria, of course. And the political and scientific shifts at that time actually led to the establishment of the School of Tropical Medicine in London in 1899. In a fundraising event for the London School, Chamberlain stated, quote, "The man who shall successfully grapple with this foe of humanity and find the cure for malaria shall make the tropics livable for white men. He will do more for the world, more for the British Empire than the man who adds a new province to the dominion of the Queen. The pursuit of controlling malaria in service of further conquest ultimately led to the Andes region of South America. Quinine, our first truly curative intervention for malaria, comes from the bark of the cinchona tree, native to that region, and only found at the time in that region. So prior to the arrival of the Spanish, of course, the indigenous population knew of and were using this curative intervention. And that spread to the Jesuits when the Jesuits began working in that area. And then, of course, that knowledge was transmitted back to Europe as early as the 17th century. But, of course, the relentless race to colonize more land in Africa and around the world led the Dutch, the British, and the French colonial governments to express great interest in the cinchona tree, which each of these governments attempting to collect and transport the seeds and the trees and transplant them into their own colonies in Africa and Indonesia and India. Because, of course, if you controlled the cinchona tree, you controlled power and the greater opportunity for colonial expansion. Eventually, this race led to the devastation of the local cinchona population in the Ecuadorian Andes. In 1805, explorers documented upwards of 25,000 trees. Recently, that same area now counts just about 29 trees. Closer to home, for those of us who hail from the U.S., the public health architecture of the U.S. was also being shaped by war, of course, and malaria. In 1942, the Public Health Service established a program known as the Office of Malaria Control in War Areas, or the MCWA, with headquarters in Atlanta. The primary purpose of the MCWA was malaria control and prevention in areas surrounding military bases and industrial areas in the Southeast, which were still quite malarious at the time, in order to protect soldiers and folks concerned with the production related to war. MCWA was incredibly successful at reducing cases and deaths from malaria in its more 4 years of existence. It also became clear the impact of the MCWA went far beyond the war emergency. The U.S. government recognized the wisdom of a specialized program on vector-borne disease with a single unit that was well coordinated, trained, and equipped. And so, recognizing the success of the MCWA and the need for expansion into other areas of public health, the U.S. established the Communicable Disease Center in 1946, which, of course, as we now know, and is today known as the Centers for Disease Control and Prevention. And so when you look back from the 19th century efforts to colonize Africa, to the destruction of the cinchona trees, to the establishment of the CDC, the history of malaria is really tumultuous, inextricably linked to a desire for greater power and control. That history then begs the question and really frames, at least, how we should potentially be thinking about accompaniment, which is understanding that history, understanding these power dynamics. What is our moral imperative? And what is our role of accompaniment in our efforts to right the wrongs of the past and to work with countries, in PMI's case, to eliminate malaria? Another story. In 2002, we'll go back to 2002, again, those early days with Dr. Jerome and others, I was working in Las Caubas. We had started up it was a Santé Santé, like a small clinic with some in-hospital beds. And I happened to be on call on Saturday, and a gentleman came down. He walked about 4 hours, and he had a urinary catheter and a bag for that catheter. And he came from a place called Dobabouge, and it was very far away. And he came to get his catheter changed. And Harvard Medical School taught me a lot of things, but shockingly not how to change a urinary catheter. Fair enough. And so I called the head nurse and to help change the catheter, and she wasn't around. Her name is Michelo, an amazing person who taught me so much. And so I, of course, the guy had come from very, very far away, and so I was getting upset, and And it was a couple hours before we were able to track down Michelot. And I was unkind and probably rather obstinate because I felt that she should have been there. And she changed the gentleman's catheter. He went on his way. And then she didn't talk to me for 3 weeks. Somewhat appropriately, I might add. And I tell that story because these early lessons in Haiti really helped inform how I see accompaniment. And that story in particular, Harvard Medical School, coming from these, not ivory towers, but maybe ivory towers, I'm not sure how we should call them. These places, you know, I thought I knew. I thought I had an air of authority about me. I didn't identify in that way, but I certainly carried myself in that way. And Dr. Jerome and others, but particularly Ms. Shillow in this instance, really helped me understand what my role really was and should have been, which is much more of a position of humility and listening and understanding the value of proximity to those who I was striving to serve, and understanding the complexity of what I was engaging in. And I learned a hard lesson that day about being a Blanc in Haiti. And I thought I read about Haiti. I was Paul's research assistant. I thought I knew a little bit, but clearly I had so much to learn. Not the least of which, by the way, was that it offended my sensibilities that the Haitians called me Blanc. Because I'm like, well, I'm black. Where's my street cred? I had none. But of course, understanding Blanc and the meaning behind Blanc was so much more than a white guy. It is the understanding of me as a foreigner. It's understanding what I represent. It's understanding the role of the U.S. in Haiti, which had some dark times, and the history and representation of colonialism that I embodied with my mere presence. And so that was a critical lesson for me, an early lesson, but an important one. And I bring these lessons to this role at the U.S. President's Malaria Initiative to integrate an ethos of accompaniment into one of the world's largest and most complicated and difficult bureaucracies. But at its core, accompaniment is about being present and in true partnership with an individual or an entity. And again, I'll go back to our friend, Paul, who said it, I think, better than anyone ever has. Quote, "To accompany someone is to go somewhere with him or her, to break bread together, to be present on a journey with a beginning and an end. There's an element of mystery, of openness in accompaniment. I'll go with you and support you on your journey wherever it may lead. I'll keep you company and share your fate for a while. And by a while, I don't mean a little while. Accompaniment is so much more often about sticking with a task until it is deemed completed by the person or people being accompanied rather than by the accompagnateur," end quote. So Paul's words, again, prophetic, but it makes it sound somewhat straightforward. And it's, in my experience and in my trajectory, anything but. It's messy, it's hard, it's complicated, and I can assure you I've made innumerable mistakes. And so what does it really mean to take Paul's words from theory to praxis? And how do we do that, or how do I do that? How do I approach it in a system that feels, frankly, at odds with those goals? And what are some of the opportunities and pitfalls? And so, look, I don't have the answers here for you. I'm not going to pretend like I know the answers. But in this role, these are things that I wrestle with every single day. And I'd love to just share with you a little bit about how I think about it. In 2006, as Professor Wirth mentioned, PMI was established by George W. Bush, and it had a budget of $30 million in 3 partner countries, And it was charged with reducing malaria morbidity and mortality by scaling proven interventions, mosquito nets, indoor residual spraying, so spraying insecticide in people's walls, in their homes, case management, the care of the patient, and preventative medicines for pregnant women and children. But over the last 19 years, next year is its 20th anniversary, it has now grown to 30 countries in sub-Saharan Africa and the Mekong Delta, with an annual appropriation not of $30 million, but of $795 million. So with that growth comes unprecedented opportunity, but also really, really deep challenges. And the way in which PMI is structured, national malaria programs, usually a subset of a Ministry of Health, our PMI central partner in each country, our in-country staff, because we have folks in country, are working hand in hand with national malaria programs to identify priority investment needs that are aligned with the host country's malaria control strategy. It all sounds great, right? No. In reality, it's so much more complicated. In the first 15 years, however, PMI and the set of interventions that we had, frankly, was rather concrete. We had, again, I'll go back, we had indoor residual spraying, we had nets, we had diagnosis and treatment, prevention of malaria and pregnancy, and there was very little daylight at all between what our partner countries were asking for and helping us align with, and what we were really thinking about as well. And the result was astounding, frankly. Malaria deaths and cases plummeted. In 2005, when PMI was announced, malaria killed upwards of 1.2 million people each year. But by 2019, that package had helped reduce that number to 409,000, contributing to incredible gains, not only in saving lives, but also in education, productivity, and economic development. But of recent, not the least of which COVID disrupted, gains in malaria have really leveled off. And we're now in a very, very different place with malaria. I'll nod my hat to Noor, who just walked in, who I look to help me understand some of these challenges. Thank you, Noor. And some of those challenges include drug resistance and insecticide resistance, eroding the very tools we have to combat malaria. We have a new invasive vector coming from Asia into Africa that acts very differently than her Anopheles sisters in where she bites, how she bites, the time of day she bites. Climate change, obviously, is not only increasing climate shocks, floods, cyclones, but also timing of rainy seasons, really challenging our efforts to protect people against malaria. Population from 2005 to 2024 in countries that have a fair amount of malaria have doubled. But global funding has not doubled, I can assure you. And we currently have a $3.7 billion deficit, at least in what WHO is estimating we need versus what we have. So in this context, at PMI, we're really faced with how do we help countries make these choices? What does it mean to accompany a country, a national malaria program, when every single country in the PMI, every PMI partner country is saying to me in particular, hey, David, we don't have enough resources in order that are commensurate with the aspirations and goals that not only we have, but these national malaria programs. And sometimes we actually, there's some daylight, more daylight in what we're thinking versus what the country is thinking. We don't always see eye to eye. And yet when we don't see eye to eye, how do we make sure that we're remembering the history, remembering the inherent imbalance of power that we embody and represent just by the fact that we are PMI? And what's the right approach when a partner country wants to take programming in a direction that we at PMI have a little bit of difficulty supporting? Sometimes because we don't agree actually with the evidence. So we're debating. I know you all in this room are no strangers to academic debates. And so sometimes we're debating the science. And then sometimes there's actual restrictions on how Congress has mandated that we can actually spend these tax dollars. I'll give you a concrete example, operational research. And how we think about operational research. Our mandate at PMI is really to scale proven interventions, but it's really hard to scale proven interventions when there's heterogeneity and still open questions about what is the best way to do so. And as we do that, what does it look like to partner with countries? In that same paper that I noted by Doctors Bumpin and Nebo from HSPH, in that paper they also specifically called out PMI because PMI had made a grant or created an award for research institutions that didn't include local partners in Africa. And they weren't wrong. And we took it to heart. And certainly as we look and has understood what are the ways in which we actually are going to shift the way we do things in a model of accompaniment, how do we do that? Over the last 2 years, we've really tried to change our approach now with new local organizations. By local, I mean African organizations, because that's obviously where our focus is and the majority of the world's burden is, where these research organizations are co-developing and co-leading projects and addressing these operational research challenges. But it's tough for us because we aren't able to do as much as we want to do. We aren't able to fund operational research as much as we want. There are questions that have to be answered, and we have to balance, say, for example, when the Minister of Health of Sierra Leone, a country in which we work on, is asking us to help him in his vision of eliminating malaria in Sierra Leone. What are the priorities that we can address, and how does operational research fit in? And the other priorities that, frankly, he has, and his deputy minister, and his other folks, and the folks in the National Malaria Program. It's a very difficult equation. And so we'd have to lean into these opportunities and compromise, and I have to ask my team. You know, I think when we think about sort of the USAID has now sort of a what we call a localization agenda. Really, again, what it really means is putting agency, small a, the power of these decisions, of what people are, of these institutions, instead of having it come all from USAID and the sort of essentially the way we've done aid, frankly, over the last years, and shifting that over time. It's slow, it's painstaking, but there's movement and it's happening, and we're really trying to accelerate that at PMI. And so while there's a lot of challenges in terms of how we can accompany and the tensions that we really face, there's also opportunities because we're the U.S. government and we have, we represent a part of the U.S. government, and there's unique opportunities that are afforded from that platform. If you just look at drug and insecticide resistance, it's a great example. And so when we think about insecticide-treated nets and artemisinin-based compounds, obviously combination therapies, they've really been instrumental in improving outcomes for malaria. But again, we have documented insecticide resistance in 30 out of the 30 PMI partner countries, and partial artemisinin resistance in 3 of those countries. We've seen this movie before. We saw chloroquine. We saw the resistance to chloroquine. And I think as a global community, we acted too late. So what does it mean for us to begin to stem the tide, act quickly, with urgency, with these challenges, both for insecticide resistance and partial artemisinin resistance? The insecticide resistance equation is almost the same power that we yield, or can wield, I should say, for the manufacturing process and drugs, which is market shaping. The U.S., through PMI, represents upwards of $1 billion of consumables, therapeutics and ACTs, RDTs, et cetera. And we've leveraged that to engage with other folks at, say, the Gates Foundation, MedAccess, and the Global Fund to really work on market shaping and reducing the prices, for example, of these insecticide-treated nets. I mean, again, I learned those lessons from so many of you in this room when I was bearing witness to some of the work that PIH was doing and others were doing when this was an issue with MDR-TB, when it continues to be an issue with HIV. So this is not new, and yet we have considerable abilities to actually move that forward through PMI. And using that purchasing power to, work with companies. We don't want to alienate those companies. They're the key to manufacturing these commodities. Work with them to reduce the prices to make sure that we have try to achieve equitable access for everyone. It's an ongoing process. And again, I can assure you that we still, Professor Wirth and I are still having conversations about drug resistance and trying to create much more urgency in the global community because we're behind. There's several countries in Africa which have documented partial artemisinin resistance. And if we look at I'm looking at Professor Wirth, who is an expert in this field, and not that it's the same story, but we are at risk of a very similar story of the pace of artemisinin resistance happening as it did with chloroquine. And we have an opportunity now to stem that tide. We're optimistic that these efforts can really change how we think about our role, what we can do, and how we move these challenges forward. And I think, again, I look at market shaping as a role in accompaniment, right? If you look at, say, for example, the countries where we're helping procure products and deploy products, working with these national malaria control programs, what they say to us is, PMI, we need help in both procuring the nets, but we need more effective tools. The right accompaniment mode for us is to say, well, then what is our role to do that? And market shaping is one of those significant roles. And of course, investing in the science. But we also have, as you all know, an incredibly exciting new tool. Not one malaria vaccine, but 2 new malaria vaccines. And so in that opportunity, of course, we have challenges, right? Because we and the countries are facing now challenges of prioritization. If you have a fixed budget, relatively speaking, right? You have your donors and their budget, and you have the country budget, and now you have a new tool. How do you introduce that tool in a way that is additive, reducing malaria morbidity and mortality, and additive to the program? And there's a debate right now, but it's not an unfamiliar debate. And the debate somewhat centers on cost effectiveness. We all have seen this movie before as well. And it's very interesting to be in this role. I'll go back to proximity. When I talk to ministers, deputy ministers, when I talk to moms, when I'm able to go visit our programs, they're not talking to me about cost effectiveness. What they're saying is, we need the vaccine, and we need it now. And so I strive to listen to them. But in most of the conversations that I'm having, it's not, again, in Washington or other places, Geneva, I'm surrounded by folks who are saying something very different. Using cost effectiveness often can be weaponized, used to stop conversations, to stop the deployment of the fruits of modern medicine and science to those who are asking for it the most. There's no ambiguity here, because there's no daylight between what they're asking for and what's needed. And yet there's debate around cost effectiveness. And I think when we look at these studies of cost effectiveness, let me assure you, we have fixed budgets. I can't ignore cost. But so often when we think about cost effectiveness, what isn't really calculated is, well, what happens when we don't act? How many lives are we willing to forego? Are we okay with more kids dying? And I don't say that gratuitously. It's just it's the metric, right? When we think about malaria, morbidity, and mortality, we're looking at, and we read the World Malaria, Noor has been the author of the World Malaria Report. We're reporting on deaths and cases. Are we willing to have more kids die, and pregnant women, those most at risk, because we're in these endless debates in these seats of power. Distal to, not proximal to, those who are asking for these effective tools. And so, again, at PMI, we're really trying to push forward. We're really trying to make sure, and again, I will go look at Professor Wirth, again, engaged in these conversations all the way from the WHO to, talking to the Honorable Minister of Health of Sierra Leone, who I learned yesterday will be deploying the malaria vaccine Friday. So actually, I'm going to applaud that because I think that's incredible. And I'm incredibly excited for Sierra Leone. And I'm excited for all the kids who are going to be protected. And hats off to Sierra Leone. We had a chance to talk yesterday, and I was, we're putting the vaccine into the usual regular EPI schedule, and Minister Dembe said, "Wow, we have some of the best results in Africa of vaccinating kids," and so we are very confident. But he said something else, and the deputy minister said something else that I think is incredibly important when it comes to listening. He noted some of the challenges, the lessons they learned in Ebola. And he said, we have to continue to listen to the communities. We say that all the time. Like, we say it, we know it, but I don't necessarily know if we do it as much as we say it. And so, so how do you get to such incredible vaccination rates? And his response, and the deputy minister's response, was, because we're talking to people, we're listening, but we're doing it in the non-urgent times. When COVID, we didn't, they had incredible COVID vaccination rates as well. It wasn't about doing it in the crisis. It was doing it in the in-between times, when you actually have space to have those conversations, have space to have those to understand and truly listen. And that's what we're also endeavoring to do at PMI. One last story before I close. About a month before I stepped into this role, I was working at the Brigham on the wards in clinical medicine. And I had a patient, and the patient was in and out of the hospital, and he was there with a gangrenous foot, and his foot needed to be amputated. And he, at some point in the hospitalization, it was taking a while to call. I was talking to ID and infectious disease and talking to the surgeons. And it took a while to coordinate the care. And he said, "Look, I'm tired. I'm gonna leave." And he had left before with the same gangrenous foot. And he said, "I'll stay, but I don't have any cigarettes. I need cigarettes, and I don't have any cigarettes." I said, "Okay." So I'm embarrassed to admit, I should be proud, but it's somewhat awkward and embarrassing to admit, for the first time in my life, I actually bought a pack of cigarettes. My mom would be proud. I think she's listening. Hi, Mom. But I had never, so I went to 7-Eleven, which is on the corner, and I awkwardly walked in my hospital ID. I'm like, "I'm here to buy cigarettes." And so I bought this gentleman a couple packs of cigarettes and gave them to him. And he said, "Okay, great, I'll stay." And I mentioned that because I didn't think about it as a feature of accompaniment at the time. But when I reflect on that, I would also, I guess, part of the story is I was heavily criticized for that. But this is complicated stuff. What is my role as his physician in an accompaniment way to help him with the greater good? Yes, I enabled his smoking. Of course, he shouldn't be smoking, but he had his foot amputated, without which he might have died. And as I reflect on that, I reflect on this challenge that we all have in this when we try to embody accompaniment about trust. How do we continue to trust those who we strive to serve and those who we strive to accompaniment even when it's uncomfortable. How do we go, particularly at the US government, and how do we evolve from wielding power to yielding power? Which goes back, of course, again, to proximity and listening. So I go back to the fundamental principles that on my journey that I learned. Leading with humility, thanks to Michello. Being in proximity to those we serve, truly listening to those we strive to serve, and really being uncomfortable as we work, particularly at PMI, to change the systems that are so incredibly slow to change and not, frankly, not designed to change with any great quickness. And when I think about accompaniment, I think what that looks like, whether that's buying a pack of cigarettes for this gentleman who stayed in the hospital one day longer or several days longer to have his foot amputated, or really thinking about advocating at the highest levels of, in these global circles, of changing the trajectory of anti-malarial drug resistance. I'll close with a quote from Maya Angelou, who, before she passed away, put accompaniment in a way that I think is just absolutely brilliant. She says, quote, "There's an African-American song from the 19th century, which is so great. And it says, when it looks like the sun's not going to shine anymore, God put a rainbow in the clouds." Imagine. And I have so many rainbows in my clouds. I've had a lot of clouds, but I've also had a lot of rainbows. And one of the things I do when I step up on the stage, when I stand up to translate, when I go to teach my class, when I go to direct a movie, I bring everyone who has ever been kind to me, black, white, Asian, Spanish-speaking, Native American, gay, straight, everybody. I say, come with me. I'm going on stage. Come with me. I need you now. So I don't ever feel like I don't have any help. I've had rainbows in my clouds. And the thing to do, it seems to me, is to prepare yourself so that you can be a rainbow in someone else's cloud. Someone who may not look like you, who may not call God the same name you call God, if they call God at all, you see. They may not eat the same dishes prepared the way you do. They may not dance your dances or speak your language, but be a blessing to someone. That's what I think, end quote. That, my friends, is the essence of accompaniment. That's our charge. And that is what I will leave you with today. I challenge all of us, each and every day, to be a rainbow in someone else's cloud, especially for those we strive to serve and help guarantee the right to health. Thank you.
We do have time for questions. Thank you so much, Dr. Walton. Now everyone can hear me. And we do have some time for questions. So I'll open up for questions to our audience. And we may also have some questions from online. Maybe I'll start. I see Olivia nodding, and she's managing questions from our online audience. So please go ahead, Olivia. Thank you.
Yes, thank you. A few members of our virtual audience were hoping to hear your thoughts on colonial structures around vaccine production and distribution specifically, and the PMI approach on collaborating with vaccine programs towards scalability and sustainability in country. Thank you.
Sure, it's a great question, and I'll look to my left at Dr. Katz, Dr. Ingrid Katz, who is a friend, a colleague, also comes from these parts and still in these parts, and now works for PEPFAR. And I look her direction because when I think about that particular question, both at PMI and at PEPFAR, really along with Ambassador Nkengasong, who's the head of PEPFAR, and now the Global Health Security Bureau. This is a significant push, not only by those of us in these roles, but also by the US government to say, COVID taught us very significant lessons around access. And most of the folks that when Ambassador Nkengasong was at the Africa CDC, helping to get vaccine to folks, it helped us realize that local production, not only of vaccines, but also of commodities, right? I didn't necessarily talk about that in commodities, but both those of us in global health are focused on how do we get more vaccine production by African manufacturers? What does that tech transfer look like? How do we encourage vaccine manufacturers to really sort of set up production facilities there? But vaccines are only part of the question and part of the equation. We have to think about the rapid diagnostic tests for malaria, for HIV, all the commodities that we're using that come, most of those, I think forgive me, I don't know the statistic, but upwards of 90% of those commodities come from outside the continent. And so when you look at global disruptions, whether it's in the Suez Canal or what have you, or COVID, these shocks disenfranchise the very folks who are relying on them the most, who have no production capacity. And so part of our goal, and there's policy conversations, but also working with governments to say, how do we continue to both foster the production of vaccines and commodities on the continent? But it also, and it isn't as necessarily as easy as sort of saying to the companies, go forth and prosper, because it also, and again, this is not my area of expertise, goes to trade laws and how do you, if you have a regional manufacturer, say for example in Nigeria, what are the trade regulations and laws within that part of Africa or across Africa to allow for that trade to happen, right? Because every country isn't going to have a vaccine manufacturer per se. So it's sort of it's working with our African colleagues, particularly the African CDC, who I know is taking a lead role on this, to really think about how we can support them in an accompaniment fashion, I might add, to buttress the ability for these companies to really continue, because there are some, by the way, expand the production both regionally and locally within Africa.
Thank you. Professor Wirth.
Thanks. David, that was wonderful. Maybe you commented a bit, but I think this is a bigger problem that TB is going to face, HIV is facing, is this in a limited financial envelope or resource envelope, how are we going to balance, what are existing interventions versus new introductions? And, the vaccine is new for malaria, but there'll be a vaccine for TB soon. Malaria will have new drugs, new insecticides, new approaches to vector control. And I think this framework of how we together think about how to prioritize, what are the values, and I think that's a question that we faced in some ways with COVID, but there was really only one real choice for the intervention. So can you give us your thoughts on that?
No, it's a great question, and I, you and I were speaking yesterday. So I think malaria, when we look at the pipeline, well, what's coming down the pike for malaria? We have the vaccines, very exciting. We have additional new tools, right? We'll have spatial repellent soon and a few other things. But as we expand the toolkit, the money is not expanding. In fact, relative to the investment, it's shrinking. And so this issue, this challenge of prioritization is one that I think is really, really tricky. Again, I'll look at my friend and colleague over here, Noor, who in his role previously at the WHO was really the architect of subnational tailoring, because subnational tailoring is actually part of how we should think about that, particularly in malaria, but obviously with other pathologies as well, of understanding gone is the sort of blanket approach for the same tools for everyone, everywhere, regardless of risk. Risk is heterogeneous, right, in any country. And so the better data we have about understanding transmission and the dynamics of, say, malaria in different areas, we can begin, the countries can begin to tailor their interventions to those subgeographies, which of course is a much more, to borrow a phrase, surgical approach. And that is important, but the prioritization of, say, this is a conversation we're having every day with countries. How do countries prioritize the new vaccines with the other interventions in malaria? The money is not growing necessarily. And so what do you, like, you have a fixed pot of tools and a fixed pot of money. What do the countries not do in order to make space for vaccinating kids? Or what do those trade-offs even look like? And so our approach at PMI is to say, we're fundamentally there to accompany these countries and the national malaria control programs to say, we don't have the answers. We know that the approach should be guided by data. It should be guided by the heterogeneity of transmission and protecting those who are most at risk. But there are going to be difficult decisions that they are going to make, and we're hopefully going to help them make, around the trade-offs that are needed to be made in this space where we don't have enough funding and we don't have enough the resource envelope isn't enough. It isn't commensurate with the challenge that we're facing. And so there's no one answer necessarily, but to me, it's a process. It is a process of accompaniment. It is a process of sort of making these trade-offs and learning and understanding as we look to bend this curve and improve morbidity and mortality, particularly of malaria. But I would be remiss to say, because I'm in my role as the coordinator for PMI, I want to emphasize that, I know when Ingrid thinks about PEPFAR and when I think about PMI, sorry, he just put a thing that said end. I'm like, end. We think about them, we reflexively think about these as vertical interventions. They started as such, but in fact, that even in and of itself was a bit disingenuous insofar as we could have never globally achieved the results that we have achieved in TB, in malaria, in HIV, if the systems themselves were not strengthened. Yes, the funding is somewhat vertical, but I won't speak for PEPFAR, but I know, because I've spoken to the ambassador enough, and I know for us at PMI, we do as much as we can to strengthen the system itself, because we all know, we've all seen the lessons of hyper-vertical programs and the failures that they introduce, and frankly, worsen the issue rather than improve it. And so I just will end by saying so much of what we think about, again, Minister Dembe, who you'll hear from later, will talk about hopefully his vision and his approach, which is the embodiment of improving the health system, and has asked me in our last conversation, how is PMI going to help me, Minister Dembe, achieve my vision, which isn't just about malaria. It's about the health of everyone in the country. And that is our charge. That is our challenge. And that is what we strive to do. Thank you.